Welcome to this video, where we will be looking at the signs, symptoms, investigations and management of a pneumothorax and tension pneumothorax. If you haven't already done so, be sure to check out our other video where we discuss the pathophysiology. Firstly, let's look at the signs and symptoms that can be present in patients suffering with a pneumothorax or tension pneumothorax. Patients may present with a shortness of breath, as they will be attempting to compensate for the reduced pulmonary function. As the affected lung fails to expand, ventilation will be less effective, and more demand is going to be placed on the functional lung. Patients may also have an increased respiratory rate, otherwise known as tachypnea. The lung affected is not participating in the gaseous exchange of oxygen and carbon dioxide because it can't adequately ventilate, which means the rest of the pulmonary system is going to have to work harder. As we know, it is carbon dioxide levels which have a greater effect on respiratory drive, as opposed to oxygen levels. As gaseous exchange within the alveoli is impaired, it can cause hypercapnia, which is high carbon dioxide levels within the blood, which will then trigger chemoreceptors in the brainstem, increasing respiratory drive. The chemoreceptors that sense a change in carbon dioxide levels not only trigger the respiratory center, but they also trigger the cardiac accelerator center, leading to an increased heart rate. Reduced pulmonary function will also put a greater demand on the heart to provide oxygen to the cells of the body. Patients may also have a pleuritic chest pain due to injury and pressure being placed on the pleura. Patients may have cyanosis, which is a blue discoloration which can be seen centrally, such as the lips or tongue, or peripherally, such as the fingers. This is caused by a lack of oxygen bound to red blood cells. Patients will often have reduced oxygen saturations as ventilation is reduced. A sudden decrease in saturations may be an indication that the pneumothorax has developed into a tension pneumothorax, especially in patients who are receiving positive pressure ventilation. Patients may be confused or agitated, which can be caused by hypoxia if the patient is failing to compensate. The patient may be hypotensive, more commonly seen in a tension pneumothorax due to kinking of the vessels in the mediastinum, but can also be caused by the disruption of venous return. As negative pressure is created within the thoracic cavity during normal ventilation, this causes a suctioning effect that increases filling of the right ventricle. When this negative pressure can no longer be created because of a pneumothorax, it will lead to a reduction in venous return, and therefore cardiac output. You may see unequal chest expansion and reduced movement, as the side of the pneumothorax does not adequately fill with air, also known as paradoxical movement. On auscultation, you may hear diminished breath sounds, as air does not properly inflate the alveoli. On percussion, there may be a hyper-resonant sound due to air trapping within the pleural cavity. There may also be hyperinflation, which is seen in the later stages of a tension pneumothorax, as air is unable to escape from the pleural cavity. Finally, there may be jugular venous distension. This is seen in the later stages of a tension pneumothorax, as the vessels in the thoracic cavity become kinked and blood is unable to return to the right side of the heart. During a physical examination, a pneumothorax may present with multiple clinical manifestations, like the ones we've just discussed. Starting with an inspection, you may notice an increased respiratory rate, cyanosis, use of accessory muscles to assist with breathing, paradoxical movement of the chest, hyperinflation of the side of the pneumothorax, and injury to the chest wall that could cause a pneumothorax or raise the suspicion that a pneumothorax may be present, such as a penetrating wound, flail segment, or bruising. When palpating the thoracic cavity, you may notice that there is unequal expansion of the chest wall as the patient breathes in and out. This is because the side of the pneumothorax has reduced ventilation and therefore will not fill with air and expand. You may also be able to feel any injuries such as broken ribs and crepitus. Percussion allows us to assess lung tissue density, but can have its limitations as the noise generated by percussion won't always penetrate into the deeper lung tissue, and noise in the ambient environment can also make assessment difficult. The test is performed by comparing the resonance throughout the thoracic cavity. Areas that have increased amounts of air may produce a hyper-resonant sound compared to the rest of the thoracic cavity. Finally, we move on to the auscultation aspect of the physical examination. Vesicular sounds are normal breath sounds heard throughout lung tissue. In areas of reduced air entry, the breath sounds may be diminished or absent, although this is not always the case as breath sounds from other parts of the lung may be conducted and heard. Now we have identified what signs and symptoms may be present in a pneumothorax and tension pneumothorax, as well as the assessment method that will help identify these manifestations. Let's move on to look at further investigations that can be used to help in the diagnosis. Other investigations include a chest X-ray, and preferably this is done with the patient standing upright and taking a deep breath in. The first step is to look and compare the apexes on the chest X-ray. In a pneumothorax, air will rise to the apex of the affected side, and this will present with apical asymmetry on the X-ray, with the affected apex typically being darker. Secondly, you can identify the affected area by the lack of lung vasculature present over the area of trapped air. Finally, you can identify the margin of the lung showing obvious space between the lung and chest wall. You can also use a chest X-ray to measure the size of the pneumothorax, and you may also notice a mediastinum shift in cases of a tension pneumothorax. A CT thorax will provide greater accuracy in identifying and measuring a pneumothorax, especially if the pneumothorax is very small or if the patient has multiple injuries. An ultrasound may be performed and is particularly useful in the pre-hospital environment. During ultrasound, we can identify whether lung sliding is present. Lung sliding is the parietal and visceral pleura sliding over each other during inhalation. If lung sliding is present, then a pneumothorax is unlikely, but it is important to remember that lung sliding may be absent due to other pathologies, such as an effusion, which is why history and physical examination is so important. If the lung point can be identified, which is the point of transition between lung sliding being present and then becoming absent, then this is a pneumothorax and defines its borders. Now let's look at the management of a pneumothorax and tension pneumothorax. Oxygen should be provided to patients to help maintain oxygen saturations above 94%. These patients may also require pain relief, and it's important not to oversee this during your management. A small primary pneumothorax, where there is less than a 2 cm rim of air on the chest X-ray and the patient has no signs or symptoms, then treatment and intervention may not be required, and the pneumothorax may resolve on its own. These patients often require some worsening advice and a follow-up appointment. If a primary pneumothorax is causing the patient any signs or symptoms, or if the rim of air is greater than 2 centimeters, then needle aspiration of the trapped air may be required. This involves placing a needle into the thoracic cavity guided by ultrasound and aspirating the air from inside. However, alternative treatments may be required for those with secondary pneumothoraces, those with underlying lung disease, bleeding disorders, or for patients with a tension pneumothorax. If aspiration fails or the patient is hemodynamically unstable, then a chest drain may be inserted. This is the primary management in a tension pneumothorax or where aspiration has failed. In emergency situations, especially in the pre-hospital environment where these clinical interventions are not always available, emergency decompression of a suspected tension pneumothorax may be conducted. This involves inserting a large bore cannula into the second intercostal space, mid-clavicular line, or fifth intercostal space, mid-axillary line, on the side of the suspected tension pneumothorax. The needle is inserted on the superior border of the third rib, if using the second intercostal space, or the superior border of the sixth rib, if using the fifth intercostal space, which avoids the nerve and vascular plexus that travels along the inferior borders. This will allow air to escape and reduce the pressure accumulating in the pleural cavity. In a pneumothorax, air is able to enter and exit the pleural cavity with inhalation and exhalation. Therefore, this intervention is not indicated. In a tension pneumothorax, air is able to enter the pleural cavity but is not capable of escaping. By inserting a large bore cannula or chest drain, we are creating a two-way valve that now allows air to escape the pleural cavity. Needle decompression is not a definitive treatment, and depending on length of time to hospital, the procedure may need to be repeated if the tension pneumothorax starts to develop again. Continuous reassessment is essential. To recap, signs and symptoms associated with a pneumothorax and tension pneumothorax include a sudden onset of shortness of breath, chest pain, tachycardia, reduced breath sounds, reduced oxygen saturations, and hypotension. Thorough assessment and history take is essential to identify the possibility of a pneumothorax and tension pneumothorax. Investigations may include a chest X-ray, CT scan, or ultrasound. A simple pneumothorax may resolve on its own. Other interventions include needle decompression, aspiration, and a chest drain. Thank you for watching, and I hope you found this video helpful. Be sure to check out our other videos, and if there are any topics you would like us to cover, then please leave a comment in the comment section below.